Good morning and a warm Friday welcome to those around the world joining us for Intravascular Imaging Live, our live case series from CCC Live Cases, broadcasting as always from the Cardiac Catheterization Lab at the Mount Sinai Hospital in New York City. I am Nitin Barman, your moderator for today's session, proud alumnus of the lab and Cath Lab Director at Mount Sinai Morningside. So today we've reached a notable milestone of our first anniversary of the Intravascular Imaging Live series and are excited to present our 7th case. It's a great case utilizing IVUS in the management of severe calcific CAD in a spry nonagenarian. As some of you may have noticed, this case differs from our initial email blast due to some scheduling issues on the first patient's end. But this change could be considered fortuitous, as today's case will parallel some recent IVUS data from ACC and I'm sure stimulate a fascinating discussion. As always, the main purpose of this series is to demonstrate the value and technical execution of intravascular imaging from a truly practical point of view, with the hope that it'll translate into more appropriate use in our audience's practice. So with that said, let's get started. As always, we'd love to hear from you in our interactive chat, so please send us your questions right from the website or through the YouTube channel. I will be monitoring the chat throughout the session, and your participation definitely adds to the value of the program. The full case will be posted on our website, www.ccclivecases.org, as well as our YouTube channel in the next day or so. So if you're unable to see today's program in its entirety, definitely check it out on the archive forum. As mentioned, we have a great 7th case for you all today, so let's head over to Dr. Kinney and the team in the Cath Lab at Mount Sinai for today's live case. Dr. Kinney?
Yeah, good morning, and it's a beautiful spring morning here in New York. Yeah, after having a bad snowstorm year for this year. So myself and we have Amit Huda right here, and my fellows who is Sophia and Bharat who is next to me, and then of course Kiski, who actually probably will have a lot to say, having visited ACC this week. And then our usual people who is Will and Asif and Kim, who is helping us during this live case. So if you can show the slide. That is case number 7. Like you mentioned, we have completed 1 year of this imaging series, and we know that our viewers are actually wanting to see more and more, like we said, how to incorporate imaging in their daily lives. So this is our disclosure, nothing to disclose. So case number 7, compared to what we had, sent on the email, it's a different case. A 90-year-old male who actually presented to an outside hospital with the angina class 3 that was, few weeks back, and hypertension, hyperlipidemia, diabetes. We don't know the reason for cirrhosis, but he does have, but all of his labs are okay. Platelet is slightly low, but it is just below 150 or so. So what had happened is he had a recent hospitalization outside hospital with a non-STEMI. At that time, he had a cath there and was diagnosed with 3-vessel disease. You'll see when you see the angiogram, and echo there also showed that EF was normal. Creatinine clearance was slightly lower. So today the creatinine is about 1.5 with a creatinine clearance about 45. And he was put on good medical therapy and sent home. And at that time also, they had a, I would say, heart team discussion because of 3-vessel disease, elderly, as well as with these comorbidities. It was discussed that patients should either get a complex high-risk PCI or consider medical therapy. They decided medical therapy, but now patient continued to have symptoms and came here for a second opinion, and that's why he's with us here. So once I've seen the angiogram, you will see our plan will be to do IVUS-guided PCI of the LAD with appropriateness criteria. Every way this patient is appropriate 3-vessel, but most important is heart team discussion was done, and I think we discussed this a lot, that how this is playing an important role in every part of a patient. At the end is the patient that's going to make the decision. That's what had happened is because of ongoing symptoms, they came here for the thing. So if you go back to the angiogram, if you can show the angiogram. And then we will go to the, so this is where we are. So without dye, you can see lot of calcium, tram track calcium. So you will see, I would say, just after the septal significant disease, there is involvement of a diagonal also, a major diagonal, which is about moderate size there. And proximal circ, I would say still about 60-70%. And then this is the lady we have here is the significant RCA disease also. We can see everything here. Circ does not have any. So good thing is left main is reasonably okay. Then we did a good caudal picture to define LAD, which is also okay. So our goal is that we will go ahead and consider LAD PCI. The question always comes is, if you see the RCA, there is almost subtotal now, and you might say TIMI 2.7 or TIMI flow is less also, that why not RCA and why has to be LAD. So if we saw the EKG when he presented initially to the outside hospital, he had subtle T wave changes in the anterior lead. So based on that, we had decided we will go ahead with the LAD, but then having looked at this RCA, this RCA probably will need intervention soon, which we will plan. But today we will focus on the LAD. So before, definitely based on the calcium itself, we will have to do some kind of atherectomy. So we will plan that we will do, probably he will say, I don't know. What do you think, Kiski? I think the way we teach, you do not need IVUS before. Let's do rotational atherectomy first, and after that we'll do IVUS. Everybody agrees?
Yes,
So let's go back to the slide. Why IVUS is very important. Go back. Yeah, this is the slide that we ought to see. So why was systematic intravascular imaging has become very important in the recent days, which is in the last few years. And what we are trying to say is, since we are going to discuss the cases, the trials that were presented during ACC also, is why intervention, if you are doing imaging, that you have to do pre-assessment and stent deployment, which is very important, and post-assessment. Why pre-assessment is important is to understand plaque morphology. In this case, we do not need it. Angiographically, we are seeing severe calcium, so let us do some kind of atherectomy. If it is just moderate calcium or superficial calcium, and you need to know, can I just get away with a balloon or atherectomy rather than doing any kind of atherectomy, that's the time intervention, pre is very important. Also, pre is very important to understand the stent, I think, length, and more the newer imaging modalities, as well as a lot of other I would say software are coming into existence, where we can use AI to understand the stent deployment, exactly where to place the stent, because that probably is the key to make sure your stent deployment is at the right spot, and subsequent outcome depends on that. And of course, once you have done the lesion, means you understand after the stent deployment, and post is very important to understand the proximal edge, distal edge, and stent, I would say MSA, as well as what I would say is the index, which we will show you later. So going back to the case, having done that, and I think we have gone through this slide before, normal to normal landing zone, how to get the diameter. If you are using EEL, which I don't like to use EEL, I always like to use lumen diameter. If that's the case, round it up to the closest 2.5. We will teach that to you today as we are doing the IVUS, after we have done the IVUS of the rota, before we consider the stent. But very important is proximal to distal reference. I think this is where the key, if you do not follow these steps, and that's when I think your outcome could differ. So the post-optimization, we have gone through these numbers, but remember that number of IVUS is 5.5, OCT is 4.5. Left main, we are not doing it, but remember, proximal left main more than 8, distal left main more than 7. This is post. And we need to keep this number. So remember, very easy to remember. 5.5 is good. So if you think anything above 5 for LAD circ, then you can say 7 is distal left main and 8 is proximal or ostial left main. So if you can remember this number, it will be good. Let's go back to the angiogram and start doing the case. Any questions so far?
Nope, not yet here, but I think you can never review that slide too many times. I mean, that's the crux for the IVUS in terms of the utilization of it.
And what also I think our goal during this live case is to understand interpretation of IVUS, which probably people have to learn from the imaging. So what do you think, what size we will use burr? What's the burr size?
It looks like a fairly straight vessel. A little turn at the left main into the left main from that caudal you could see, but
okay, some dye. I think we thought we are engaged. Okay, good.
Yeah.
Okay.
There you go. Now is that you can exchange for the RotaWire, Dr. Kinney?
Yeah. I have a floppy ready. Let's see how it behaves.
Yeah. I mean, if the microcatheter passes easily, I think a 175, still reasonable. It's a pretty huge looking LED.
So one thing is for early beginners and all that, they want to understand the size, of the.
Yeah.
It's like first it went in, and now I think we lost the tip. So you have both 1.5 and 1.75 burr.
Yeah, it's a function of a lot of things, as you know, for the audience. Obviously, the reference diameter of the vessel is the starting point, but many times we'll downsize from what we might take as a 0.5 ratio, burr to artery ratio, and downsize for a variety of reasons. There you go.
Okay, now look at how the vessel is.
Yes.
Right? Okay, now some dye here. Oh, God.
You could have noticed on that the wire was kind of very separate from the calcium. Some of that calcium maybe.
Yeah, adventitious.
Adventitious,
some
right.
dye. I'm trying to see where are we going. Oh, into some. We're going in a small septal, and then.
Looks a little more favorable, right?
Yeah, so if you can get the U loop, and that's probably the best thing. Now look at the wire bias.
Yeah.
Very, very pronounced there.
Yeah, so I think what
maybe
our goal should. Yeah, what do you think, Amit?
Yeah, 1.5 would be safer given the tortuosity, calcified, and the wire will be biased towards one side.
Remember, the one is 1.5 and the other one is, if you don't do 1.75 burr, you do not, then if you see that, you'll end up probably.
And we can always supplement with another modality like IVL. No?
Okay.
Yeah, here.
Oh, we have.
Yes.
Okay, give one. I think will be.
I think. Yeah. Are you?
1.75.
Yeah, I'm not opposed to that. Yeah.
And we are just going to do just at the level of the septal. Okay. The rest of the area we will leave it alone.
I think that's a key, is a really controlled burr, so you don't turn the corner into the kind of true mid LED.
Okay, 1.75. People may say, I would like to image and understand. So we are the one who made that algorithm, right? That how to do a burr size. Now we have done burr size. All our publications in the past is angiography based on angiography, and then we said 0.5. Now we are 0.5. In the very earliest days used to be 0.6, 0.7 even. Those were very early days of rotational atherectomy. But right now we are going 0.5 just because we have other adjunct modality.
Yeah.
So we will do that. We will have our other workhorse wire, which will be our run-through wire ready. After rota, we will have the IVUS, right? 3 to 5. Yeah, 15. What is that? Oh, 3-0 you took. 3-0?
We took 3-0, but
3-0?
you can take 3 to 5.
It will be a 3-5 vessel, that's for sure.
For sure, 3.5. Yeah, I might have taken a 3.5 as the.
Yeah, 3.5, but give us a shorter one. Hopefully it will go because. Okay, ready?
Yeah.
Yeah. Let me see the number. Okay.
Did we have some idea of the EDP there? I know his EF was preserved, but
18.
18. Okay.
We gave some nitro and the EDP went down to 15 when we were doing it. So that's important that we always say 14 to 15 is the normal. Anything higher than that, our fellows, nurses, they always they remind each other, let's give some nitro and take another EDP.
Dr. Kinney, we have a request to show the steps of atherectomy,
Okay.
while you're advancing and setting there. So
you saw that we checked the speed, but usually Rotus Pro is very good now. You don't have the pedal and the speed is always about 150 or so. In rare situations, only we may have to go up. So I'm at the left main there. You see there? Stay there because we are going to burr right from there. And then once you're done that, 3 steps, right? First of all, when you're going up, you're on the dyna. Dyna is a safety mode switch, which means that by mistake you have pressed here, or in the past used to be the pedal, that if it starts spinning, it is no more than 65 to 70,000 RPM and nothing is going to happen. So now later on I will show, I have shown it in other live cases, why it's important that you need any tension that you have to be removed from the rota bar. So you have the knob, you see the knob? So this is 1 centimeter. So we have 90 centimeters. So you go backward, forward. So any tension between the Teflon sheath and the burr is gone. Next is a Y connector, which I'm going to go backward, forward. You see that the burr is moving, which is good. And that means the tension between the burr and the wire is gone. And the last step is on dyna, you just do a tap. So you do, yeah.
Very
you see
nice.
that? Very nice movement. That is how you start. So off dyna, and what's going to happen is Asif is going to read out the numbers to me. We are going to start, okay? Slow and slow
Very
pecking
controlled.
motion.
Yeah, you can see the turn there. Yeah.
So it's definitely going down. See that? Yeah.
We're not getting a great audio on the burr sound, but that's a very important part of the procedure.
Okay, you start seeing some EKG changes also, which is trying to tell us we probably should have gone 1.5. Let's try a little bit longer. 130, 5 seconds. You want to go up a little bit speed? Yeah. 5. 55. Okay, good, enough. Because when I'm reaching the bar, 140, 150, 5 seconds. 145.
The key is the patient's here watching the EKG, and
I think we go.
Yeah, I know. every time I decide between
You see that? It's not going to do that. It's still a long way to go.
Yeah. There it's engaging there.
Oh, yeah.
Now it's going to go. Now it's going to go. Yeah.
You heard that noise? Or you? I don't know.
It's pretty low volume for us, the burr sound, but yeah, we
Okay,
did.
okay. Low volume. That what is trying to tell us that more important is blood pressure and EKG. So what is happening is some fluid is going in, but more important, I have Will in the back. He has his syringe filled that we keep giving some neo. So with neo, what happens is you do see reflex bradycardia. So it's not a good drug if you're doing RCA. So you may
RCAs.
need if you don't have a pacer, then you may have to have aminophylline bolus in your hand to take care of that.
And the patient, should be hypertensive and bradycardic. So if they're bradycardic and hypotensive, then you got to do something additionally.
Okay.
That looks like you might be sufficiently through.
Yeah. I think I don't need to go because we do not want to make that turn. You see that?
Yes.
Once you make that turn, then we will go into that spiral. So I think we are good. Yeah. See that? Nice. You see that? Yes. Okay. So this is what I would say we did a polish run. So once you do that, you do the polish run, and then we're coming out. Get me the run through ready. So the key here is slow packing motion, and look at the speed we did. We did at 150, 155. So what was happening is as we are engaging, the RPM was dropping to 135, 140. So we also say if there is more than 5,000 RPM drop, which means that there's a lot, the disease is significant, a lot of calcium, but definitely is doing its job. But like we showed you here, be slow, gentle, okay?
Yeah.
Let's take a picture immediately. So far, hemodynamics are okay. Okay, which we expected. Now, other thing is it because of the large burr or is it a thrombotic lesion? Patient had a non-QVMI, so that is another reason maybe we should have probably considered smaller burr.
Lower size, yeah.
Yeah. That in the setting of non-QVMI, which we have done in heavily calcified lesion, small burr, just to, create a little path. Things are okay, only thing is the EKGs. We're going to do a quick IVUS.
Yeah.
We have a balloon ready, and always have a balloon ready.
Yeah. Little bit slow flow, so I think the safety first.
Do a balloon first.
Because still slow flow.
That will be better.
Yeah, and another trick here is you can always put the microcatheter over the rotowire.
Yes, yes.
And then deliver medicines.
No, that's one, but more important is wiring also.
Yes.
If I'm going to find it too difficult, you can use the same.
Yeah, that's a great point what Dr. Kinney just mentioned. If the side-by-side wire doesn't go easily, then you should always just exchange for a 300 wire over the rotowire. But during that, oh wow! So even
look at that.
Yeah, so much friction. So the guide moved with just the wire, right?
What Kiski is saying is that since there is slow flow, which is true, try not to do IVUS. Let us just balloon. And now, was slow flow for two reasons? Was it a large burr causing slow flow, or was that because of the setting of non-QVMI and some thrombus in these lesions?
I would argue the former, that it's just a heavy calcific burden and a large burr, yeah. And listen, it's always easy in retrospect, but the other side of the equation is efficacy.
Yes. Okay, go up.
12.
Okay, down.
You can see the eccentric inflation of the balloon all to the septal side.
Okay, go up here. So we are going across the diag, okay? Yes.
16.
Okay, down.
Nice expansion.
Okay, we are going to do the imaging, right, Kiski now? And I'm not making this turn. You see that?
Yeah.
Nothing is making a turn either. Let's go. I hope people understood the steps of the rotational atherectomy. Any other discussion there? Yes.
Yeah, there was some questions I answered offline about giving aminophylline, generally not in LADs.
Yeah.
If the RCA is not chronically occluded.
Yeah, better flow.
Excuse me.
Still bit
Okay,
slow.
give us the IVUS catheter.
Okay.
Look at the diagram.
I was going to say, and you're probably going to have to do something about that, right? I don't know if there's a landing zone proximally.
Yeah. Not even that. Yeah. We have double wire. Hopefully, IVUS catheter will go in. The balloon has gone. It's a short monorail, so
yeah, I think we noticed that just the wire motions were oh, look at that.
I tried to do the quick clamp.
no,
Oh, it doesn't
that's
close.
it now.
It doesn't close. Yeah, eccentric calcium
Okay.
here. It doesn't close. Okay, start pullback. It's
Yeah,
in the
start.
middle of the lesion.
Yes, I know.
Eccentric calcium and proximal. I see some dissection, diffuse plaque.
And a nodule too.
Yeah, left may also have some plaque.
Yeah, but it's
I will stop it.
non-obstructive.
Yeah. You can take it out. Yeah, start with the pullback, eccentric calcium, and the other half is plaque free. This is the most dangerous lesion, the risk of the population.
Where is that?
Yeah, this is the start of the pullback.
Oh,
We didn't cross this.
yeah. We saw that.
Tightest. We did already 1 fiber and balloon, but still, yeah, calcified.
175.
Yeah. So, let's just go that at the tight. I mean, based on the balloon expansion, we're okay. The reason I think we see this is calcium. There could be a lot of disease, entire LAD.
Yes.
But taking the patient's age into account, let's just focus, right, on the tightest.
And also at the edge of the calcium and the normal part, I think this is a dissection, so it's in the good modification. We cannot see entire calcium fracture in this part, but at least we see some dissection. So it's if we do more aggressive, it's a risk of the population. So. Yeah.
I think we did a good modification.
Yeah,
so let's go back to the point. Show us where the tightest area is.
Yeah.
This is where.
Yeah.
So the question is why IVUS catheter would not make a turn into the LAD? Why did it just stop there? Is it the tight lesion, or we think because of the way the LAD, wire bias because of the calcified LAD?
Yeah, I think both, but still the MLD is 1.3. We are not sure more distally because we didn't cross. But the start of the pullback, MLD 1.3, and eccentric calcium still there. But I see that revalvulation, it means the surface of the calcium is shaved by the rotor. That's a multiple reflection. This is a sign of the shaved surface of the calcium. So this also means a good sign of the modification.
Okay. So essentially what we are trying to say is I think we have done good modification. Let's go and do a stent.
Yeah. Yes.
Agree?
Very much so, yes.
Yeah. So
we have a number of factors: the way the balloon looked, the reverberations there, and then the fluoroscopic and intravascular dissection are all speaking towards stenting being the next step.
So the question is the length, and other one is the size.
Yes.
Now, I would go 3.0, and then if you want, we can post it. Length is questionable if we are going to cover that diag or no, even either way. If we can do 28, we will be just at the level of the diag to that where the other lesion starts. 32 may not make a turn.
I think if you're planning to jail it, you may need to wire and balloon it first. So the flow seems already corrupt, and I think
No, that's what my angiographic assessment. Let's go with what Kiski is telling us.
So,
just foreshadowing the some of the trials we'll discuss. But I'm sorry, go ahead, Kiski.
Yeah, there is a diffuse plaque as we see, and actually there's no good landing zone based on this IVUS. So that's why it's good to do the lumen sized sizing. And after that diag, there's a okay landing zone. The lumen is 2.9.
Oh, really?
So maybe,
So if there's a landing zone after diag, why do we need to cover the diag and get into more complexity?
I mean, area is okay. And another point, if we have time, we can talk that. So this is the AI integrated Avigo Plus, and it shows the area is 20.
It looks
It's really
big.
curious number, but always we should make sure this button, and it's long because of this a lot of calcium.
Yes.
So this kind of complex lesion, sometimes AI fail to measure the accurate lumen. That's why we need a manual area assessment. So we can believe like 90% most cases, but this kind of complex coastal lesion, sometimes AI miss. So we should do manually measure assessment.
So your job is safe, Kiski.
Still, yeah, I have.
What do you think? Dilate
What do you
the
want to see in the caudal view?
caudal didn't show much.
Yeah, I think you need to dilate.
it
It's a big diagonal. We're not even seeing it fill there.
Okay, get us a 2512 regular balloon.
Yeah.
I know if it is, we'll say cut it. My issue is there is calcium there, and I do not want extra work on the diag.
I think gentle PTCA to just keep it open is reasonable.
That's it. Yeah, that's it.
Let's see here.
Okay, it does not look bad here.
Yeah.
Huh?
I mean, just the wire, I think, helped it probably, but
So in this view, just like what Kiski said, there is a good landing zone afterwards. We can just put a 28 and
Yeah, that's another option, I would say.
yeah,
More.
we will leave the wire and just put a 3 or 28 below there. Okay, okay, I'm telling 28. Kiski, give me your length below the diag.
But I don't have an IVUS image listed, so
Oh, yeah, because we did not cross a lesion. Forget about it. So we will have to go with the EYE IVUS. Right?
yeah.
What do you think?
Yeah, I think that's
You want 28 or 24?
24 would be okay.
Because we don't want to make a turn into
Yes.
that thing.
what was the length of your balloon? Was it 15?
That was 15.
12.
Yeah.
12.
Huh?
Was it
No.
That was 12. They gave 12. Like
12 or 15?
12.
Oh,
I think a 28 would be.
too long.
That's a 12. Yeah, I think 28 would be too long.
No, 24. We are going to go 24. Agree?
I think that would be
That's what we
perfect.
were
Yeah.
thinking.
Yeah. Okay. 3 or 24. I do have 3 wires, but I am leaving the what I'm saying is the rotor wire there, so that once the stent is there, we'll remove it, because I'm not sure it'll be easy to deliver the stent. Patch PCI, just the tightest area. EKG is getting better.
Nice.
Yeah.
You're beyond the diag.
Okay, we are beyond the diag. Yeah.
Yes.
So I'm going to remove the rotor wire.
And that's
So
a key step,
24
obviously.
probably is, yeah, very, very important. We have that wire there. You guys wanted it, diag wire. Okay, good. We'll take a picture.
Yeah, it's amazing how
much calcium.
friction. Yeah, and how
Yeah.
much it's drawing the guide in with very little motion. Yeah. Oops.
Okay,
You're good at.
I think you are good.
Yeah.
Yeah.
Okay, go.
And hopefully then we're post IVUS, which
I'm 12.
Okay, that's good.
that's a 3x24, correct?
Yeah,
Yeah.
Down.
I think that's a good choice.
28 would have been too long, and we did not go to the area distal to that.
And I think the audience probably recognizes this change in camera view to really understand the diag origin. That's really critical to come more LAO.
So it is LAO or caudal. In the caudal, we did take picture before. We could not see the ostium. So very proximal diag. Many times, LAO caudal can give you
Yes.
what the ostium looks like. Okay, beautiful.
Beautiful.
Angiographically looks beautiful. Let's see what Kiski is going to tell us. Diag, you see that? We didn't do anything. We had the wire.
Less is more many times
Yeah.
in life. Yeah.
Especially in elderly patients, so many comorbidities, number one, and you see a lot of EKG changes. So you start interfering into all these areas, you could just get into a spiral. So we need to have complex case, made simple, right?
That's the key for sure.
Yeah.
So we're going back with IVUS before we post-dilate. We may need to post-dilate, I guess. We need, oh, that was the fielder wire, that's okay.
Yeah.
Still doesn't close.
Still not going in that angle there.
Yeah, I might need a second wire.
Yeah.
Oh, did it pop through? No.
No, I took it out and let me see if the fielder will go, and then maybe we go with the fielder. Now this was just to
Nice.
like we have an imaging session once, we have to start a calcium session.
Yeah, I know, right? There's a big overlap on all those. Yeah, I mean, it doesn't have any balloon support right now, so yeah.
No, not even that. Everything is like, I'm going to try again. Let's see. Get me a new fielder. Can you see anything there?
Yeah, I can check the image. Yeah, it's within the stent. Yeah, this part is good expansion.
Expanded?
Yeah, this level, but we are not sure more distally.
Okay, come to the proximal edge.
Okay, start pull back.
Yes.
In the middle of the stent. Okay.
Okay, go back, go. Let's do again. Okay, stop.
Okay, 1 second. Check the image. Live. Okay, start pull back.
Nice image.
Coming. Yeah, on the plug. Yeah, diffuse plug.
But that looks.
Stop it. Yeah, quickly check. You can take it out. Yeah, stent looks expanded. Yeah, we knew that it's on the calcified plug.
But that was okay,
Yeah.
right?
I don't think there's any way to. Yeah.
And it might be a slight dissection here, but I think it's minor.
But that was there.
Yeah, and the proximal part of the stent is expanded, and now this area is
7.1.
Yeah.
Give me the run of.
Yeah, so proximal
fielder.
part of the stent is expanded. Proximal edge is on the plug, and at least no major dissection. Yeah, so proximal part of the stent is good. This I'm not sure.
Okay, I'll try to go with the fielder wire.
Yeah.
So this is one thing I think very important point. The more complex, I know they say imaging is very important, complex, which includes calcified lesion, long lesion, left main, bifurcation. But you see how things are, that imaging catheters don't go. So many times you'll start and you'll end up using, EYE.
Yeah, I think the hallmark of a good interventionalist is to be able to adjust your plan in the middle of the case based on how things are going. I mean, and again, we all would love to have the images, and obviously you're going to try here more, but, it's always big picture, whether the patient's 90 or not.
And Keski would agree, like one of the downside, if you go very aggressive with placing the IVUS in these lesions, sometime you may end up deforming your stent also.
For sure.
Angiographically, it looks good. I think we'll try, but if it doesn't happen, we had a fantastic result on angio.
That's a great point, Amit. That looks behind.
Yeah, I'm going.
We show the initial IVUS after rotor and the balloon. There was the eccentric calcium, and the other half is plug free. So that's why even the vessel size is 3.5. Even after stent, aggressive balloon might cause the perforation. So downside and the kind of defensive sizing is safe and good.
Might have been a small pseudo lesion in that section too.
Yeah, see that what happened is probably okay, now we're okay. Yeah. We even in the very early first time we were wiring, we have had so much issue there that It could be he had a LAD that is curly Q now calcified, and we are having this.
Yeah, that's probably okay for the or the wire there. Let's
Yeah, it's
see.
in a small branch, which I'm always. Let us see if it does not go. We got to take in this view, and what we will do is we may have to just post dilate it with the 3O and call it a day. If we're not going to get too aggressive to get this catheter in the distal edge. 12, maybe an 8 now, because 12 was not making a turn. Now I'm on the fielder wire, so we are double wire, okay?
Beautiful.
No, I don't think we went distal.
Oh, that was
either.
just the proximal tip, huh? I don't know if you could take maybe a deep breath, but he might be out for the count.
If we take the run-through wire, we may be able to, because if I get more aggressive, we may start dissecting the distal
I was just
LAD
going
now.
to say that's kind of the enemy of good or enemy of perfect, whatever the saying is.
It's telling us stop here. 2 wires have been destroyed. You see that?
Yeah, it just doesn't want to
Unless-
pass that mid-distal junction, which is.
Okay, ready there. Let's take a good picture again. Before you give dye, let me show you the amount of wire bias we have here. Yeah.
And there's a question about the guide extension, but I think in this case the same principle applies. There's so much disease proximally throughout the left main. It would really, the risk reward may not be in favor, but certainly it's something we consider to deliver. But I don't know how you feel about that.
No.
Yeah.
Because, like you said, in the proximal area, we already have disease, okay, which angiographically, I think we would say leave it alone. What do you think?
Yeah, I agree with that. And I think
Diag is okay, right?
Yeah.
So there is significant disease of the LAD, okay, after that where it is going way further down. That is probably, we can see now we are not even able to wire it. Look at this. Okay, let us take another picture.
Wow. Yeah.
Sucked into the left main. Okay, are we there? Okay. Little bit nitro or no? Vasodilators.
I think it's not unreasonable, all the no reflow he had, or the slow flow rather, not no reflow.
Okay. We are going flush. EKG is back to baseline. We still have some ST changes. Back to baseline. Okay.
I think we have a really good result on angio.
Only my worry is the distal edge of the stent, right? Did we think we have done a good job?
Maybe even less caudal. Yeah, right. Yeah.
Okay, there. You will see it. Okay.
Yeah.
So now, bring shutters in. Bring the lung shield back.
Yeah, this orthogonal view is so good for the mid-distal edge.
Yeah.
Very nice.
I think angiographically looking okay.
Yeah, I don't see any concern for any dissection at edge of the stent.
And also, if you see there,
Prox,
the LED where we are having issue and all that, which is again about, I would say 60-70%, it's probably a bridge also, bridge with calcified lesion, which again is, so we can give more vasodilator, so open it up. Yeah, blood pressure is in the 80s.
That's a good point. You can see a little dip in the vessel there, so that really kind of implies that, and like it's.
You see that dip?
Yeah.
And good thing is we stopped our rotational atherectomy way before
Yeah.
that. Okay, and that's one that we would say is a no-no. And all my fellows know that. You know, one of the part of the LED that you have to be very cautious. Ramus diagonal. If you think that it is a bridge, try not to use rotational atherectomy unless you're really forced to do that. Even in that situation, has to be a smaller bar. Okay, but all the time avoid, otherwise just avoid it, because the risk of even if it's not frank perforation, you see the vessel that will you would say the early perforation, and that's how things start spiraling down. So these are the things also you need to know when not to do and what not to do.
Yeah, that phenotype is pretty typical for perforations when you get aggressive in a elderly person, especially in mid-LED peri bridge section. Yeah,
it's really good.
I think if everybody agrees, let me take one caudal picture, and then we just go with some of the discussion, which is okay. I have some more time for the discussion, and that's good.
Yes.
Right. We're trying, you see that this is also an issue that we try to see the diagonal in a very caudal view. The proximal edge, which he said was some dissection that we saw, but I'm going to go larger and bring it down. You see that?
Yeah, to really look at the.
Yeah.
Yeah, we did have a question about the proximal edge dissection, and certainly if it's small in length and arc, it can tend to heal. I think the flow is preserved in that.
In that diag.
Pretty big diagonal, branching diagonal. But yeah, I think it's very reasonable in this case to leave that alone.
So if you see the EKG, no EKG changes. So let's go back to whether we can, our decision of leaving the diag, go back to that. They want to know, and then I'll show you the slides based on, but most of it is all OCT guided decision making. Where is the clicker? Clicker is.
Yeah.
That was OCT based decision making. Can we go on the. Yeah, so this is where we are post optimization, which we spoke on, right? That is a edge dissection. You see that, what we are talking about? See that picture of the edge dissection that you see there on the IVUS, and let's go and show our IVUS right now for a minute. And Kiski, you tell us. Okay.
Yep.
Okay. So this is the proximal. Go back to our IVUS. Okay. Yeah. Come back.
Yep.
Pull back.
It is a native.
Yeah.
And you see the 7, 8 o'clock. There's a small flap here.
Yeah. Right there.
But we knew it. We saw it before the rotor and the balloon. But we don't have a healthy landing zone. So that's why this is our decision. So we knew this residual dissection, and I don't think this is come to the media, and the longitudinal length is also less than 2 millimeters.
Can you measure that?
Yeah, I can.
Yeah. Yeah. So the so we'll go back to the slide. Longitudinal length has to be less than 2 millimeters. He's going to measure, and other important is not come back to. You see that the length is that the arrow you're talking. Look at the picture there. That arrow. Right, where we put
yeah, that's the cross-section arc. That should be the less than 60 degrees.
Yeah.
Yeah, and the longitudinal should be less than 2 millimeters.
So then, show what are you talking about longitudinal?
So longitudinal is like here. I measure like 1.6.
Okay.
Yeah. And
now go back. So he's saying the measurement is 1.6, means the length. You see that? The length like this. You can see me.
Yeah.
That's my. Yeah, that is 1.6. And the arc, if you see the arc, so arc is, he's drawing it. You can see the, means from the center coming down. It's probably about 35, 40 angle.
Well less than 60.
Yeah, well less than 60.
Yeah.
So based on all this criteria, I think this is a very important teaching point today, that when we can leave it, because it's proximal LAD, people will be worried to leave it alone. But then if you go behind, or if you go back and stent, again we may get into issue, because there is some mild plaque everywhere in that situation. Yeah.
Well, plus you involve the diagonal then again, which changes the things. And we know from all of these, we always will find minor edge dissection so much more with imaging, right? That we didn't really even see it on the fluoroscopic.
Yeah. Okay. So that was the question, and then go back. Otherwise, we could not get to go back to the slides. Let me just quickly go through some of the slides that we have. No, go back where we started, where you stopped. Okay, yeah, this is where we were. We went through this slide, and I think we go through this slide every time because this is something like I say,
Yep.
you wake up in the morning and when you're brushing your teeth or something, put this slide here in your memory card of the brain and just keep remembering that what is it that you need to remember, the numbers that we went through, okay, which is very important, and the dissection. You see that? The dissection should be limited to the intima, and length should be less than 2 millimeter, which we said how to measure. Kiski just showed you how to measure. And the arc, you see that the yellow line that we have made, which is edge dissection, that has to be less than 60 degrees. So based on all that criteria, what we saw right here does not meet that we can leave this alone. You agree?
Yeah.
Yeah, we agree. So we are going on to some of the discussion. So before we discuss why, what the results of the ACC, we know now imaging has become class 1 for the ACS cases in here in the US, and chronic coronary syndrome out in the European guidelines. So based on multiple trials, so some of the trials we will go through the old trials and we are going to compare it what was presented and to see because now all of a sudden we are being told you don't need to do imaging, your eyes are as good as IVUS, which we have been preaching in our live cases, but you know, people who are out there have to know from us that what is it, should we do IVUS or not do IVUS? So Renovate Complex PCI, which came out in 2023, key points. So it came out in New England Journal. So it was done in complex coronary disease, just like today, right? True bifurcation, CTO, left main, long lesion. When they talk long lesion, anything about 28 millimeters and above, multiple stents, severely calcified osteal lesion. So all these are considered complex, and today's was severely calcified lesion. And they took what is called as a hard endpoint, which is cardiac death. So if you see here, first time they're showing that all these endpoints, angiography guided PCI versus imaging guided PCI, significant benefit if you do imaging guided PCI with a hazard ratio of 0.64. Why? Why did this show that? Because they followed the strict criteria what we just showed, that stent deposition, stent expansion. So stent expansion is a key, which is more than 5.5 millimeter in the regular vessel, or if it's left main, we gave you the number. That's why we are going over and over that you got to remember this number. And other thing that is important is that what is called as the stent expansion index, which has to be more than 80% if it's at a particular lesion, which we are going to show how Kiski is going to calculate that, or if you take the distal reference as more than 90%, most of the time go normal to normal. Not in this particular case, but if you can go normal to normal, that is the best. And what happened also is, in this particular trial, if you see that pre and post evaluation was done in almost 75% of the cases. Now, these are the numbers you need to remember, and then we compare the recent ACC trials. So plaque burden at the landing zone less than 50%. Do we agree in our case today?
Today
Yes.
is not. Today is no, because we don't have a good landing zone, so this is a limitation.
Okay. So. Anyway, so less than 50% was in 91% of the cases. So you can imagine they really did a good job in doing so. And no major dissection, okay, and stent malapposition was 0.8%. So I would say perfection. They went for real perfection by using imaging. What if you see here, optimized result met all the criteria. Remember the criteria they have here? So 55% met this optimization criteria in this trial. So that is why if you met the stent optimization criteria, look at their outcome, half. So very important to meet this criteria, but if you met the criteria, then you become half. So this is the key, that if you think you want to do imaging, then you got to be a perfectionist and you got to do a perfect job in imaging, do pre, do in between, get the exact stent length and where to place the stent, and do a post and make sure everything is by the criteria that is placed. That's the only way you'll get a good outcome. And we saw that was initially at 2 years. Majority of the benefit was at 2 years, but when they followed it for 3 years, there was some benefit, but still there was not a lot of a late catch-up phenomena. So if you, after that came also October, which was a OCT. Okay, that was also presented, but this was for mostly complex bifurcation. Again, showed OCT guided was better, not a big difference like a Renovate complex PCI. Then, of course, we know the other OCT trial was the ILUMEN-4 that was presented in 2023. Now, what happened is they were not that complex lesion overall, but if when they took the sub-study of complex lesion, even in the ILUMEN-4, there was a benefit of MACE. And then we know this network meta-analysis. Why we are talking is between 23 and 24, most of these imaging studies showed there is
Very
a benefit,
positive.
there's a benefit, everything was positive. And if you take this network meta-analysis, that 22 randomized trial they took, and they said that there is a benefit, especially for your major outcome. So then, all of a sudden, why are we seeing that there is no benefit now, right? So these trials made it to the guideline. So ESC is chronic coronary syndrome, America is ACS, and you have to remember what kind of lesions they're talking about. Left main, true bifurcation, long lesion. So they're saying if in this situation, try to use imaging. For left main, they prefer IVUS, and for others, if you want, you can use OCT, and that is where it made it up to the guidelines. Now come to ACC 26. We had 2 trials they presented, IVUS chip trial and optimal trial. So we'll just go through why this was what it was. So optimal trial, if you see that, IVUS versus angio-guided PCI for unprotected left main. So if you see follow-up up to 3 years, anyway, syntax score of 29. So I already told you how important the previous trial was, the Renovate. If you see that, before the stent, okay, only about 65% of the cases. That's what the main paper said. But when you go to the supplement, pre-IVUS assessment was done only in 38.7% of the cases, compared to
Yeah, the major main paper said that 65%.
yeah, main paper 65, and the supplement was 38.
Yeah, so no data is present. Go to the CLC, so
And
some discrepancy.
Yeah, and what they did was post-IVUS was only done, and most of the time, most IVUS was done in 91% of the cases. So what we are trying to tell you is that it is critical you do pre, so you understand the correct size, the length, and the landing zone. And that is what I think is very important. And of course, they said 24 minutes longer because you had to do IVUS multiple times. So the question also comes is, they have said that these were all performed by expert IVUS operator at high volume centers, and they showed no benefit. One other important point we are also showing is that if you see the outcome, right, they are IVUS guided or non-IVUS guided PCI. The composite primary endpoint, which is still very high for this complex PCI, which is the uppermost graph. But let's go to the next slide, which is the IVUS chip trial, which showed complex lesion, which is severe calcium, the same lesion characteristics where other complex PCIs were done. So here at least the IVUS at baseline has gone up to a little bit higher number compared to in the 40 ranges, and then post was about 96% or so. So if you see here, complex high-risk PCI, because we are going to compare the 2 trials. So if you see the pullback analysis, but more important is optimal criteria that has been met. Remember, we went through the optimal criteria of post-stent placement. That was only met in half of this particular trial. Otherwise, plaque burden less than 50% was met in about only 40% of the cases. What we are trying to say is that optimal criteria probably was not met in this particular trial. So we are comparing Renovate Complex PCI of 2023 to the IVUS chip that was just presented. So if you see that plaque burden at the stent landing zone less than 50%, okay, see that 91.8% had less than 50%, which means was a perfect placement compared to IVUS chip. About only 40% was achieved. That means the optimal criteria was not met, and optimal criteria was 55.5% achieved in the Renovate Complex PCI. They have not given that number in IVUS chip, but the way that has been presented looks like it is a smaller number. You agree?
So the point is, even the Renovate showed that's a meticulous IVUS use, the final optimal result just met 55%. And actually, IVUS chip also showed that 53% met that criteria. But when you see the contents of the which optimal criteria does not met, the Dr. Key showed in the Renovate, like 91% met that the residual less than 50% burden was met. But in that IVUS chip, like 40%, they still has a residual plaque. So our point is that pulley is important to see the normal to normal landing zone and the less residual region. But this is more than 40%. This is also much more than our clinical case. If we do the like a meticulous pre-assessment to see the vessel sizing and the landing zone, then usually we don't miss that much. So I mean questioning. So but data is data. But I want to know the quality of the I was.
That's where I think we rest our case. Yes, tell us.
I might add one point if you go back one slide that it seems like in CHIP the way it's reported that each case it only had one of the criteria missed. I mean, if you add up the numbers, 40% the plaque burden, 6% of the MSA,
the minimum MSA, yeah,
and 3% of the dissection. I mean, that accounts for as if each patient that didn't meet the optimal criteria only had one, which doesn't really make a lot of sense. So there is something in there that needs to be further sussed out.
Yeah. And that's probably the reason, because I think this is such a hot topic for interventionalists who are trying to learn imaging, and we are trying to say how imaging has to be done. And more important is, I think, the stent optimization is the key, and learning stent optimization, that is the key, and I think that should be our goal. And there will be lots of discussion on this particular topic. Now, since we are trying to say that, imaging, and somewhere it also showed that IVUS had, where was, right?
Yeah, the IVUS should, no significant difference, but Kaplan-Meier curve showed the IVUS is higher TBL in the optimal trial, higher all-cause death in the IVUS. I mean, not significant, but it means the IVUS did something worse. So that's the question. So why it happens?
I'd like to add one other point. Yeah, I mean, obviously this is interesting in that it's contrary to a lot of that data and the discussion. I think one side of the discussion is optimal IVUS versus suboptimal, as we just nicely pointed out there. The other parts in some of the discussion have revolved around the experience of the operators doing angio-guided, and I think that's relevant, and I only bring that up because it applies even to the case that we presented today, meaning you consciously did not pursue every, the plaque edge burden in this case, didn't meet criteria, but it was done with your, profound experience and decision making. So there's a lot of variables at play, but certainly as a rule, it would make sense to compare optimal IVUS, or at least really an aggressive attempt at optimal IVUS when clinically appropriate to angiographic to really kind of determine that value or not.
Yeah. So we're just going to have one. Okay, we go back to the slide. We're going back to this quiz. This is a case that we did. If you see there, distal left means significant disease, and look at that 270-degree arc of calcium. So we did 175 burr and 3.5 stent and a 5 pot. The question then was that what should you do now? So I think we are going back to the point that we are trying to teach you that if even if you don't do imaging anywhere, I think imaging has to be done 100% in a certain lesion, and that is left main. So you got to be perfect when you do the PCI of the left main. So the answer here is that what would you do next? Very important, based on the guidelines also, intravascular imaging has to be in this case. So we do, look at the angiograph, right? Angiogram looks so beautiful, right?
Yeah.
If you are not done imaging, we'll say everything is looking good, done, we are coming out. We did imaging, and look what we find. Okay, this is post-stent IVUS. Remember, I gave you the number. The distal left main has to be 7. Now, can we say 6.9 is almost close to 7? What do you think, Kiski?
But yeah, but anyway, like borderline, like not optimal expansion.
Yeah,
So
but more important is what? That there is, we will show you there is something, this is not important, is there is, look at that calcium behind the stent, and in the left main, you got to get a better total MSA. You know, this is less than 7. There is a part that is probably not expanded better. So now the question, what will you do? Would you go high pressure balloon and dilate it, or would you do something else? So we opted for what is called intravascular lithotripsy, because there's almost close to 180 degree, okay, maybe less than 180, maybe what?
we did already 504, but
Yeah,
still there's
did not do
6.9 and a calcified plug behind the stent. That's why we decided to the IVL to shock the calcium behind the stent.
Good. So we did that, and the 40 mm IVL, and after that you see that MSA became 1.5. So what a point we are trying to make is that we already did pot, still no change, then you had to do something for the calcium. So this is very simple. I think we went through all this trial, which trial showed a neutral result for imaging guided PCI. Renovate was positive, October was positive, iLumen was positive. So definitely the recent trial.
I mean, for sub-study was positive.
Sub-study, yeah. Complex lesions sub-study, and of course we have our hemodynamic app that is all just presented and ready to be used. Okay, so we are done with the today's case. If you have any questions.
Yeah, there's been great discussion. Oh, sorry, go ahead.
There's one more. Wait, go back. Where's the yellow you didn't put?
Oh, for the May symposium, yeah.
Yeah, on May 5th, we will have, same CCC will cover it. Our yellow trial was presented, and we are having a 1.5 hour session on discussion of the yellow trial, and there'll be a lot of imaging even in that during that session. But I think it will be covered under CCC, so many people should log in and learn.
So
yes, and you should. Go ahead, Keski.
Yeah, I went to ACC and I watched the optimal trial and IVUS chip trial in the front of the main tent. And actually, kind of disappointed, and it's a new trial and a negative trial. And the moderate presenter said for the high volume center expert of the IVUS might skip the IVUS, but they also say that in the Europe, entire IVUS penetration is like less than 10%. So this is kind of misleading. So this kind of like a beginner now starting the IVUS, they are still not yet like experienced the IVUS operator. So they should still follow this today's Dr. Kinney's talk, post, final, systematic IVUS use, how to use, when to use. Then after you master, maybe you can choose according to this New England Journal paper. But still, the education learning is important for all the interventional cardiologists.
Good point, Kiski.
Great point. Yeah. It's actually one of the main mandates and kind of basis for this program, and learning from Dr. Kinney and yourself on this is, really fantastic. About the yellow trial, if you're on the subscription list, you'll get information about that, the symposium in May. So with that, we kind of wrap up today's case. Thanks again to Dr. Kinney and the members of the Cath Lab. Congratulations again on the anniversary presentation here. We look forward to kind of many more years of learning in this forum. And thanks to you all today for joining us for this exciting case. The recording of today's case will be archived on ccclivecases.org later today. And as a reminder, Intravascular Imaging Live will occur every other month, and we will let you know about upcoming cases. The next IVI Live case will be on Friday, June 5th, 2026. Thanks again. Have a great weekend, and see you all next time.